the way that you're going to be successful in healthcare is breaking down those silos and getting everyone to work together. And I feel like anyone who's joining or thinking about going the healthcare delivery path, it's really taking the time to understand it. You're always in a learning mode throughout your life. I recommend that for anyone. Always be asking questions, always be trying to learn.
Welcome to another episode of the Intersection Podcast, brought to you by the Georgia Tech Scheller College of Business. I'm Lionel Ouonkap, a first-year full-time MBA student pursuing my dual MD MBA degree, completing my MD at Morehouse School of Medicine and my MBA at Scheller. At Scheller, students can enrich their education when joining interdisciplinary institutes like the Institute for Leadership and Social Impact, also known as ILSI. ILSI promotes servant leadership and organizational practices that contribute to a more just, caring, and sustainable world. ILSI started the speaker series Impact in 2006 to engage students, faculty, staff, and the community on topics that matter through meaningful conversation with leaders and entrepreneurs from all sectors. LSI started hosting Impact in person, but as times change, we learn to adapt. Starting this fall, they're transforming Impact into an all-new podcast format on Intersection Podcast, where they can still dive into meaningful conversation and share powerful stories. The podcast allows the discussion to be more accessible and still as engaging as ever. I'm excited to step in as host of the inaugural episode of Impact on the Intersection Podcast, where we will be discussing healthcare management and technology. Now, let's jump into today's episode and welcome our two guests. Bill Todd is the professor of the practice in strategy and innovation at Scheller. He has significantly advanced healthcare management at his alma mater since becoming a faculty member in 2011. He has crafted 3 robust healthcare management courses, demonstrating his commitment to academic enhancement. Josh Robert is the Chief Operating Officer for Piedmont Atlanta Hospital at Piedmont Healthcare. He has over 20 years of industry and management consulting experience, leading and managing large-scale enterprise transformation. It's my pleasure to welcome Professor Todd and Josh Robert to today's podcast. Professor Todd, Josh, welcome.
Thank you very much.
Thank you, Lionel.
Thank you.
All right. So before we start, diving into our topic today, I want to give the floor to both of you to introduce yourself and share some insight about your career journey, and how you got into healthcare management. I'm going to start with you, Professor Todd.
Well, thank you, Lionel. I give all the credit to me choosing healthcare management as a career to a major professor at Georgia Tech in the 60s.
Okay.
If you think about the 60s, we were going to change the world, and we wanted to do it fast. And one of the great challenges, as articulated by the greatest management consultant and writer at the time, Peter Drucker, was that we needed to get professionally trained management people into non-traditional industries. Education, where coaches became principals who became superintendents, and healthcare, where nurses or physicians who perform well would become supervisors and then CEOs, and other organizations like welfare departments, prisons, all kinds of social service, not-for-profit entities. And he was convinced, and I think rightfully so, that professionally trained management had to stand beside those professionals with domain expertise in healthcare, education, welfare, to really create great organizations that could deliver. So early on, since I worked my way through Georgia Tech, I worked at Crawford Long Hospital as a unit clerk, now Emory Midtown. And I got interested in healthcare from an experience standpoint, and also this motivation to go out and change the world.
Yeah.
So I went to Grady Memorial Hospital as a unit manager as my first job right out of Georgia Tech. Was there for 40 years, and now in my 14th year here teaching healthcare management. So it's been my bread and butter for 58 years, really.
Yeah, that's very impressive. I'm gonna go away to you, Josh. Do you mind like sharing your insight with our viewers and listeners?
Yeah, no, not at all. So thank you for the opportunity to sit with you today.
Mhm.
So I think the healthcare journey for me has been very interesting. It wasn't something that I left Georgia Tech thinking that that would be what I would do from a career perspective. So in '02, I got out of Georgia Tech. I studied industrial systems engineering here. And I went in the management strategy / consulting space right out of college. I was very fortunate. I worked with a lot of the Fortune 500 companies, and I've always been, give it the engineer in me from the tech background, a fix-it guy. I like to look at problems, figure out how do we figure out a different way to do it. Traveled around the world, worked mostly Fortune 500 companies, a lot of really non-healthcare type organizations. So I got some really good exposure to see sometimes how things were done really well, but then other times how things maybe weren't done well by organizations. And Piedmont Healthcare was actually, back when I first started, only 3 hospitals in the state of Georgia. And they were evolving to start to employ more large groups. So the first one they were going to do was cardiology, and they were employing this huge cardiology group called the Piedmont Heart Institute. Now it's probably the largest in the country, which is pretty fascinating to see from a growth perspective. And because of my post-merger integration work, I came on board to help Piedmont essentially start PHI.
Okay.
One thing led to another, and they said, "Hey, Josh, would you be interested in coming on board full-time, working with us as a Piedmont employee?" And I said, "I'm not sure. I'm not a healthcare guy. I've worked in retail, consumer products, all these other things." They said, "Actually, that's what we want. The vision and the mission of the organization has always been to be proactive and to try to do things differently than the way it's always been done." And I bought into that. And nowhere in did it say you had to be a doctor or you had to be a clinician to be successful here. And I said, "Oh, well, try it. Get me off the road from a consulting perspective." So I spent my first 2 years there doing projects and really questioning, did I make the right decision of making this move? I went back. I got my master's in business administration. I actually got my master's from the University of Georgia. Don't tell any of my time. My body divided. But I did that, and I slowly but surely started getting more into the operations side of healthcare and trying to fix things and making it different. There's so much opportunity that I think we'll talk more about today.
Okay.
But yeah, so it's an interesting path. It wasn't that I left Georgia Tech thinking that, I'd end up in healthcare from a career perspective.
Yeah, that I think you guys have like very powerful stories and how you became into healthcare. And then to your point, like many people may think that you have to be a physician to go into healthcare management, but from your story, we see that there are other paths. So I want to stay with you, Josh, and talking about the Piedmont Healthcare. Like as a CEO of the Piedmont Atlanta Hospital, how do you balance operational efficiency while providing high quality service? And also, are there any specific strategy and technology that you use to perform your task?
Very good question. And because the ops side of me, right, as I mentioned, I'm a fix-it guy. Healthcare has historically been very broken, right? As the processes, the systems, the things that the whole industry has so much opportunity for improvement. So as a chief operating officer, that's my job, is to truly figure out how do we make these operations more efficient. And ultimately, we're there to take care of patients. So how are we going to make sure that our patients are receiving the best, most high quality care, getting the best outcomes, all the things that, of course, you would want to provide from a hospital. What makes Piedmont Atlanta very complex is Piedmont Atlanta is actually probably the highest case mix index for any, call it, non-academic hospital in the country. So I think we're number 8 now on the list. What's that mean? A case mix index is a measurement of how sick or how the acuity of your patients. So we've got really, really sick patients that are coming into our doors. We're a coronary referral center. So all of those things add just this entire other level of complexity to operations and trying to care for each one of those individual patients, because each one of them have a different situation or something going on. I think that the strategy that's been very powerful for us and why I feel that we've been as successful as we have within the last probably 15 years is the partnership with the physicians and the clinicians. Mm-hmm. So me as an operations guy, I might see a solution that was applied at any other industry that it could apply to healthcare, but unless the providers are going to get on board and really try to say, okay, yeah, that's going to really help us, it's not going to go anywhere. Uh-huh. So our governance model and our management model is very much a physician, call it partnership between the clinician and an administrator. Sometimes they call me the suit. But it is a true partnership. And when we hire a physician, it's an expectation, not a nice to have, that they are involved in the operations and the business of the organization. And that really helps us, I think, drive a lot of the change that's required. Mm-hmm. And it's been very powerful for me to watch and be involved, partner with those doctors to really drive the things that we need to have done.
Yeah. Thank you so much for sharing your insight about what you do on a daily basis and how Piedmont Hospital do to provide high quality care for the patient, because I personally believe they're the one that matter at the end of the day.
That's it.
Yeah. So I wanted to come to you now, Professor Todd. In your intro, you mentioned your impressive background, and during your career, you founded the Georgia Research Alliance, and as the founding president of the Georgia Research Alliance, are there any key challenges and success that you encounter while fostering innovation in Georgia? And can you also explain, briefly to our viewers and listeners, what the Georgia Research Alliance is for those who don't know?
Right. It's amazing how similar Josh and I think. I think everybody from Georgia Tech is a systems thinker. Mm-hmm. One school has the word systems in their title, but we're all that way. I think I must think in Venn diagrams. Mm-hmm. Where do things overlap? How can you get things done with more than one party that you couldn't do alone? And so that inspired me to try the Herculean task of bringing together three universities, Emory, Georgia Tech, and the University of Georgia, to do something important for the economy of the state that no one of those could do alone. And that was the theory behind the Georgia Research Alliance that had been given to us by McKinsey and Company, the great management consultants, but they don't ever tell you how to do that. So it befell to me to figure out how to have that vision. And it's very similar to the notion that Josh talked about with the relationship between a suit and a white coat.
Yeah.
He made a joke about being a graduate of two of those three. And so often the relationship between these universities was defined in one day of the year in November when they play football together. Yeah. Well, we have much more in common than we do that separates us. So my mission was to bring them together, find that overlap in the missions of those three institutions and the cultures of those institutions, and then use that collective horsepower to grow the economy of the state. Yeah. Three ways. Recruit companies to come here that would want to be around this brain power. Two would be to infuse these principles and these ideas and this technology into the current companies that are here of all sizes. Yeah. And three is to start new companies that came out of the laboratories of those three universities. We very quickly added three more to balance it out, to get more statewide and to be more diverse. We brought in Medical College of Georgia, Georgia State University, and Clark Atlanta University. Yeah. So we had a full portfolio geographically and culturally. And over the 10 years that I presided, from 1990 to 2000, we raised $800 million to put into these universities so that they would become these engines of growth. Yeah. And Technology Square, where we sit today, is a physical manifestation of how that did work. Georgia Tech could not have built this alone. The University of Georgia has something similar in Athens, And they could not have done that alone. Emory has a robust medical research enterprise, but without Georgia Tech, it wouldn't have any engineering. Therefore, there wouldn't be any bioengineering. So it's the same kind of philosophy. You got to have partnerships. You can't do things by yourself. And so that was really the highlight of my career. It's now been a long time since I had the highlight, so I guess I'm on the downswing now.
Yeah. Thank you so much, Professor Todd, for sharing. I want to come back to you now, Josh, and talk about technology and how the Piedmont healthcare integrate technology. So the question that I have is, how is Piedmont healthcare leveraging technology, and how to do that to enhance the service? So what are some success and challenge that you encounter like in the process?
Yeah, that's a great question, especially from call it Georgia Tech technology background, right? The technology, when I first came into Piedmont, Atlanta, I mean, we were using paper charts. I'll never forget that, right? That's 14 years ago.
That was a long time.
It was crazy. But from other industries back, I mean, everyone was computer. I mean, what do you mean we're still doing this on paper, right? Which was just fascinating. So yes, the technology advancements that have hit the industry over the last probably decade have been pretty remarkable in an industry that's needed that for so long. But we still have so much opportunity to utilize technology better. I think the innovation and the things that are coming, it's almost at times overwhelming. And we'll talk about that maybe in just one second. But yeah, we've invested pretty heavily in a lot of technology platforms, whether it's our EMR, so we utilize Epic, which is a great tool for the patient. And we continue to figure out better ways to use that. There's so many tools in the EMR system that we have not even turned on yet, which is unbelievable to me. So we're not using paper charts anymore most days, but we will use our EMR systems. But yeah, we're doing things with wayfinding, right? There's a company called Gozio that we partnered with that helps a patient navigate through the hospital, utilizing Epic to help patients when they're trying to do billing, or MyChart to go in and actually make an appointment with your provider. All of these things that I think a lot of other industries tapped into years ago. We're slowly but surely turning that on. Piedmont's fortunate. We've invested in that. Our CEO has been very passionate about the fact that we have to innovate. But I think we've still got a lot of work to do in that space from a technology implementation. And it's overwhelming. I'd say that back to the AI question. I think I get an email every day from a different organization trying to sell me on some new AI, that's the buzzword tool. Okay, what does that mean, right? And I hope we get a little time to talk about technology is only as good as it's to enable a process. We've got to fix our processes and our systems first, and then we place in a technology solution to maybe help make it a little more efficient. But
I really like the integration of Epic into like patient care, because it's like everything all in one place when it comes to like patient information and all the data. So I'm going to come back to you, Professor Todd. Like, can you share any specific innovation or project that from your career that had significant impact in healthcare management?
Yeah, I'll give you a couple of examples, and I hope Josh will agree. One is on the medical side, one's on the administrative side. On the medical side, the whole industry was shaken to the core way back in 1999 when the Institute of Medicine came out with a report called To Err is Human that said that as many as 100,000 patients die every year of something they didn't have when they came into the hospital, whether it's a medical error or infection, hospital-acquired infection, or just oversight or something. And so the industry really began to work hard to fix that. And Dr. Atul Gawande at Harvard writes eloquently about this. They turned to the aviation industry, who is well known for good safety, and said, what do you do? And the very first thing they figured out is checklists. I guarantee you that when the hero of Miracle on the Hudson pushed back. He didn't say to the co-pilot, we don't need to do the checklist. I've been flying for 27 years. We're good. No, he went right through the whole checklist. Well, today, physicians in the OR are going through a checklist.
They do.
And no matter how many times they've done it, and the most progressive, like Piedmont, are actually starting the procedure by going around the table.
That's right.
And saying, my name is Joe Smith, my name is Mary Jones, because teams have not worked well together. They've not worked together. It's like pilots for a commercial airline. They meet their co-pilot the day they go up in the air.
Yeah.
So you have to have processes that support strangers all of a sudden becoming a very cohesive team.
That's right.
Yeah.
So that's a big innovation, and technology makes that possible. You could have a paper checklist, but that doesn't really work because you don't learn anything from it. There's no permanent record when you try to evaluate a safety problem. So that's a big on the clinical side. On the business side, I think the whole concept of service line management is critical. And I was fortunate enough to be in the earliest days of that. I was the first unit manager at Grady, which meant I was the little junior baby administrator on the medical service. At that time, it was 600 and 700. So I had about 240 patients as a baby administrator, 24 years old. And I was the local branch manager, if you will, of the first floor where the mahogany desks were. But I was the local person working with my counterpart, the chief resident, who was the senior medical person on day-to-day things, and the nursing supervisor.
Yeah.
And that was a breakthrough at the time, because before everybody was on their own. And that became then progressively more logical in a way, but breakthrough, where you have Piedmont Heart Institute, which means cardiologists with all the subspecialties of electrophysiology, vascular, all of them, the surgeons, the radiologists, the interventional people, are all in the same service unit. Well, they used to be not.
That's right.
The radiologist would be with radiologists doing breast cancer, breast imaging. Well, they don't have a whole lot in common except their fundamental training. Their patients are different. So it's a hospital management philosophy of organizing services around the needs of patients. We call it patient-centered medicine or healthcare. Well, that seems so intuitively obvious, but it didn't grow up that way.
That's it.
Because you had one person who was a surgeon, another person who was internal medicine, and that's a big gulf. And then you get the other big three, psychiatry, OBG, and peds, and they're as different as night and day.
Amen.
But it's just an evolution. Healthcare is still a cottage industry.
Yep.
No system, even one as formidable as Piedmont, has more than single-digit market share in the nation. There's not a national, even HCA doesn't have market share that gives them the dominance of a Delta in their market, or a Bank of America in their market. It's still a kind of a local thing. Piedmont is dominant in the state of Georgia, but it's becoming sort of an oligarchy. And I think that's better for patients. There are dangers in it because with any kind of consolidation, somebody in Columbus says, well, we can't do that without checking with Atlanta. Right. Well, that's a problem. So there's some challenges in this specialization and economies of scale. But again, healthcare, as Josh said, was late to the party of digitization. Last industry in America to be digitized. I tell my students, can you imagine walking into your bank and saying, I'd like to withdraw $100. And they say, well, we see you have that. If you'll fill out these forms, here's a clipboard with a ballpoint pen chained to it. You would walk out. Say, I'm not doing that. It's my money. I want it now. I want to put something in a machine in the wall. This summer I traveled to both Ireland and Italy, and I got euros. Easy. And I don't know how it works. I need an engineer to tell me how it works. I don't really care. But I want the convenience, and I want the accuracy and the security. But we fall back on what about HIPAA? We can't do that because, well, you can do anything you want if you do it right.
That's right.
Yeah, definitely.
It becomes an excuse.
Yeah. Thank you. Coming to your checklist idea and that you talk about I like having been in the OR myself, I've seen how like that is very effective in preventing possible medical errors. So I think that was like a very revolutionary one. So thank you so much.
Yeah, if I can add on to that,
Yeah.
great comments on all those. I couldn't agree more with everything.
Mm-hmm.
It just that is what's happening in the industry. The checklist piece, Bill's point, you don't just run this check,
Yeah.
which has been really helpful for us to sit down with the clinicians and say, how should this be done?
Mm-hmm.
We actually at Piedmont create what's called the CGCs, Clinical Governance Councils, where we bring in play all of by the specialties. So it's cardiac, neurosurgery, orthopedics, pick the groups from all of our locations. So we now have 26 locations, hospitals, if you will, across the state of Georgia. But to Bill's point, in Columbus and Athens and Augusta, they all might do things differently.
Yeah.
So how do we then, and this goes back to the operations question too, right?
Yeah.
Because that's waste. And there's so much waste. If you have 15 different ways to put on a Band-Aid, for example, that's wasteful. And it's actually not best for the patient. Let's come up with one way that we do this that everyone agrees that's how it
Across
should
the
be
board,
done, right? So we've brought them all in a room and say, let's define how we deliver this care, and let's all agree to what this should look like. That's been very powerful, I think, and that's where the industry is going to continue to evolve, where we come up with these, call it pathways, around this is the way that care is delivered. This is how we make sure that we reduce variation to hopefully not get to what Bill's point was. That goes back to the harm. Piedmont's goal is zero harm to any patient.
Yeah.
Unfortunately, we hurt people. No one goes into healthcare to harm a patient or an individual. They're going in to help someone. So we've got to do better. We've got to be able to design these, call it pathways, to where we know that if we do that, that patient's going to get the best outcome.
Yeah.
But all of those, my brain was just swirling as you're talking about that, because that's what we talk about every day. Is as we grow and as we're trying to implement the ops and the clinical and all of these things, where are we going now with a lot of these care pathways to reduce that variation?
Yeah.
I don't know if you've rotated through Children's Healthcare of Atlanta yet on a PEDS rotation, but they have posters that say one is not zero.
Right?
Yes, I did.
And that's about a hospital-acquired infection. They're never going to be satisfied until that last one is eliminated. It's sort of like when Dr. Bill Foege eliminated smallpox from the face of the earth. One is not zero. If one person has polio, the world's at risk.
I agree. I'm going to come back to you, Josh. Like, we went through, I would say, what I consider one of the worst pandemic in our lifetime, the COVID-19 pandemic. So I wanted to know, like, how did that pandemic impacted operation at Piedmont Atlanta, and are there any like long-term changes that you personally think they will persist? Yeah,
for sure.
That is such a good question, and I think we would probably both answer it the same way. One of my students and his key employees played a critical role as a young administrator in getting them off on the right path. Go ahead and tell that story.
So, this has been, the pandemic obviously was just shook the healthcare industry, right? Probably more than anything. I think I still have a little PTSD from it, to be quite honest. It was just unbelievable. But a lot of lessons learned.
Yeah.
A lot of really positive things came out of it, but also some negative, of course. I think that for us, it became very clear that labor was going to be the biggest, call it, long-term issue or problem, opportunity that we had to address. The labor market, meaning what happened throughout the pandemic was a lot of nurses left, providers left. Any one of our departments, so many people just said, I'm not working, I'm not doing this. Pick the area. So we lost a ton of staff. And then we also then started to have to supplement or augment that with what's called contract labor. So we went out and tried to hire whatever was left. We either got to pay them a lot more or hire these contract employees. prior to the pandemic, Piedmont Healthcare, I think, was we paid about $40 million in contract labor for the whole system. Okay. And we thought that was a lot. At the height of the pandemic, we were paying about $420 million in contract labor. So huge expense.
Yeah, it is.
To the organization. You cannot survive. It was going to bankrupt the healthcare industry as a whole. Every healthcare system across the country was talking, this is not sustainable, these expenses. So we're still digging out of that. Our contract labor expense is down to probably like $230 million or so right now as a system. So it's getting better. Still a lot to do. So what have we then had to do underneath around innovation, new workflows, new things that we have to implement for the workforce, which is what Bill's alluding to. So another fellow Georgia Tech graduate who was one of our rock stars at Piedmont Atlanta, and worked in the system office on helping set up our telemedicine. So how do we now utilize technologies to where you don't need as many, call it hands-on resources to deliver that same care? So he developed we rolled out telemedicine, which is something that took us, we couldn't figure out how to do for the last 10 years. We did essentially in a month under Patrick's leadership. But that was just one example, and stuff that we're still trying to figure out. You can never completely take the human out of healthcare delivery, right? No matter what, you've got to have, a doctor's got to put their hands on a patient. A nurse has got to go do certain things. You can't just be all automated. But there are things that say, okay, what are some processes and things that I could start to utilize, like telemedicine? There's now telenursing, where you have a nurse up on a screen talking to a patient, right? A lot of those types of innovations that COVID really pushed that envelope, forced the industry to say, we got to look at different ways to deliver care. Because the way I get a light bulb, Bill and I talk about this all the time. Whenever I walk into an apartment and I say, well, why do we do it that way? And they give me that, we've always done it that way. I'm like, ding, ding, ding. Gotta think of a different way now. And we always are asking that question. If it doesn't have an answer, we do this for this reason, always done that way isn't going to solve it. So a lot of work still to do there, and we're still digging out of, call it the labor crunch, and how we deliver care without the required resources to do it.
An answer to all these questions that you're posing is the same fundamental principle of communication and empathy between the white coats and the suits. And you're so smart to be both. Because you're not going to say we've always done it this way. You're going to say, well, Bank of America has thousands of branches and millions of customers, and here's where they demand standardization, and here's where they allow creativity. And every company in America goes through these periodic, we're going to consolidate, now we're going to distribute. You kind of ebbs and flows, and you try to get the best and to optimize it, to use an IE term. What is the best way to allow creativity? Nurses are among the most creative people ever. They will make up stuff with tape and baling wire and paper clips. They will hold together raggedy pieces of equipment until finally some suit says, what are we doing? You need a new IV pump.
There has to be a better way.
So you really want them to be innovative, but you also want to have the intervention of a suit saying, wait a minute, that's a safety risk right there for shorting out a circuit or whatever. We need to get you a new IV pump. She said, I've been trying to tell you that. The paperwork didn't catch up. I didn't get that report. But I see it now.
Get that report.
So Josh is an example of a guy who believes in MBWA, management by walking around.
That's it.
When you walk through Piedmont with him, he knows everybody, they know him. And he's not sitting in a mahogany desk down in the first floor trying to run the ship from a telephone and a
you gotta be out there.
Remote control.
You gotta see how it works. It's the only way.
Thank you so much. I'm going to come back to one thing that you said. Because I personally think, I'm from Cameroon, right? And then it's a country very underserved medically, where you have like one physician for 10,000 people. And one thing that you said about telemedicine, I think those kind of idea that COVID kind of like make us look in that direction. It's something that can help not only like Cameroon, but even
Exactly.
underserved area here in the United States.
That's right.
So I personally think that was something great that COVID brought in the bad.
Exactly.
We had some good. So
Yeah.
yeah. So now,
Very well said.
There's
Yeah.
other technologies too.
Mhm.
Some of them get to be a little creepy.
Yeah.
We had an experiment in our mechanical engineering and biomedical engineering
Mhm.
where a physician had a glove and the person on the other end was putting that on the patient to palpate, to feel for pulse,
Oh,
and it was creepy.
Mhm.
We abandoned that research
Right,
because
right.
the psychosocial
Yeah.
negatives far
That's
outweighed
it.
the ability for a physician in a referring hospital to say, oh, well, that's a thyroid problem
Right.
or whatever. The
Yeah.
better solution is to train somebody there
Yeah.
to
Yeah.
actually be there, whether it's a
Yeah.
nurse or technician or something.
Yeah. It's actually fascinating to see how people like mine can work to solve like small like issue that we may face. So like I'm really like thankful to you all for sharing like this insight. So I want to ask you now like both of you like some question and feel free to like jump in and answer the question. So how do you think like the collaboration between academic institution and healthcare provider can drive innovation? Like, do you have any example in your career that you can comment on?
Well, I want to brag about Piedmont
Yeah.
because maybe I'm bragging about myself in the same
That's
time
okay.
because they accepted my advice
Right.
Yeah.
to get better connected with Georgia Tech.
That's it.
Mhm.
And they're moving their system offices to close to here. It's not
Yeah.
quite in Tech Square because it's not big enough, but they're in Atlantic Station.
Mhm.
And so they're going to be in a perfect place to be here, to walk around our labs and
That's
say,
right.
well, this is very fascinating. We need
Yeah.
this in Fayetteville.
That's it.
Or to the other way around, to be at the end of the pipeline when the students come out, to catch them.
That's it.
Yeah.
And I refer students all the time, and the admissions people, the career services people got to fuss at me about this. But one time Josh called and said, send me your best man.
Mhm.
Didn't say what he was going to do. Didn't say what kind of qualifications.
Mhm.
So I sent this person, and they figured out for this woman where she would fit best. At first, they had her plugged in at Piedmont Atlanta.
Mhm.
Then they said, wait a minute, she is so smart. We're going to put her in the system office and do process improvement for the whole
Yeah.
system. And you can't do that if you don't have these relationships.
That's it.
Yeah.
No, it's the partnership with academia it has to happen.
Yeah.
There's so much brain power. I mean, that goes back to how we first started. Healthcare delivery is very broken. We need smart people to come and help us figure that out. And whether it's Georgia Tech, whether it's Emory, pick the academic center that's here in the state that we want to partner with to A, help us solve problems,
Yeah.
but then B, that those people, those students, when they graduate, come into the workforce and become healthcare leaders, which is just, we have to continue to. And then there's the innovation side, right?
Yeah.
So how are we working and partnering with Georgia Tech on innovation projects and new ways of technology implementations, all kinds of things that we're engaged and involved with between our organizations.
So all these big health systems engage the big consultants.
Yeah.
Yeah.
BCG,
Of course.
KPMG, all these people. But for 16 straight semesters, they've come here and
That's
said, we want you to look at this very difficult challenge we have through young eyes.
Oh yeah.
And in the case of children's, our students are kind of proxies for their primary customers, that is the parents.
That's it.
The babies can't tell that
Yeah.
they're the recipient of the care, but it's the parents. And we did a breakthrough program with them where they had a 6-month waiting list for subspecialty appointments, and yet they had a 30% no-show rate.
Yeah, that's it.
Now, how inefficient can that
Exactly.
possibly? That would drive an IE crazy.
Exactly.
Yeah.
And so the very first thing we figured out with our students being Gen Zers is they weren't using an open table kind of system. They were calling the patient the day before to remind them of the appointment,
Yeah.
but they were calling a landline.
Right.
Oh.
And even if they call the mobile phone, you're not going to answer it if you don't know who it is.
Exactly.
And they didn't quite get that because the systems were designed by 55-year-olds.
Exactly.
And they weren't looking at it through young eyes.
Yeah.
And so when we did a project for Piedmont Atlanta in 2023, even the CEO was kind of taken aback when he saw them say, well, it's obvious that you have to have the 7th floor of this new building and the basement devoted to ORs, ambulatory surgery centers. And even the CEO, who is a clinician, a renowned clinician, said, "Oh yeah, I knew that." And all of his C-suite buddies were laughing. He forgot that you have to have tall ceilings.
Yeah, that's it. No, it was good. The students come and they bring a new, fresh set of perspective, right? And they're very good at synthesizing the data.
Yeah.
It's how do we take all this data? And they see things and ask a lot of questions that then you sometimes miss and present. That project that Bill was referencing around our surgery centers was just a fantastic set of work. I couldn't have paid a BCG or a KPMG to give me that work because I probably wouldn't have been as good, to be quite honest.
Well, we probably should develop a little internal consulting firm and be consultants to the consultants.
That's it.
Yeah. All right. So I want to move forward now and ask you like a question on innovation. Like, so what are some big challenges and opportunity that you guys see in the intersection between healthcare and technology?
Why don't you go back to your AI example, because it's more than a buzzword. It's real.
Oh, it's real. And that's it. The innovation, it's coming. And this will be interesting. I've been reading a lot of things on this. So if I start with a couple things. So there's different revenue cycle. You hear that. That's probably a really easy way for us to do a lot more AI or innovative technologies in the revenue cycle side of the house. How are things coded appropriately, and then how is that bill dropped and then reimbursed? And it takes all of that, call it right now, a lot of manual processes out. There's really no, call it care delivery when it comes to revenue cycle management, right? You're talking about processes, back office stuff that you could use AI or technology to help you with. So we'll look at things like that. Then there's things where you start to now get in the clinical side. And it says, all right, if I look at radiology scans, right? Let's say, 3,000 echoes. And instead of having the cardiologist have to read that echo, now AI gets involved and says, I've identified this one's fine, this one's not, so now do you need that cardiologist to read anymore? So it frees up that time. So there's a lot of conversations from the clinicians around where do we implement or use some of this that takes me out of the game. Even in terms of making them more efficient, if you will, I put that in quotes, in the office, using technology to help them dictate or their record, right? The docs, as you know, get very frustrated because it's like, I got to type everything, right? And because of that frustration, I know that the industry will innovate and it'll become almost you just talk and then it creates a chart and you're done. Well, then that means, back to my ops side, that means I used to say you could see 20 patients in a day. Now I'm going to say, you need to see 40, right? And physicians are already, I hate to use the word burnout because it's not on a clinician. I don't like to use that word, but docs are tired for a lot of reasons, post-pandemic, whatever. So some of these innovations might be, but will it force them to even continue to get more burnt out because things are thrown at them like that. So we've got to be very careful. The other piece about innovation that I want to be we talk a lot about, Bill and I, is, and it goes to the systems. We've got to make sure we're using the technology to improve. What is it improving? The system has to be redeveloped first, and then we implement a technology to help that system or that process. It's not just let's go create an app and everything's going to be better. It doesn't work that way.
If you automate a bad system, it's still a bad system.
It's still a bad system. It doesn't work. And I think I hate to say it, a lot of us as engineers and problem solvers just immediately jump to a solution without ever understanding the problem. And we look, that'll solve it. Well, will it though? Is that really the root cause problem that we're trying to solve. So we've got to step back a lot of times and spend some time on that.
That's why you got to have some management people like me.
That's right.
To temper that solving the wrong problem
That's it.
fast.
That's it.
Yeah. So I think answering the last question, you kind of touched on my next question, because I was going to ask, like, how do you see technology continuing to impact healthcare in the next decade? But you kind of touched into that aspect too. Yeah. Do you have any comments you want to add to it, Professor Todd?
It lets doctors be doctors instead of technicians.
Yeah.
When we free up the burden of the examples you used, dictation, documentation, reading scans, if we automated the system using AI for reading echoes, and they read 3,000, and then you had a cardiologist come back and look at some random sample or some that were kind of on the margin of being okay or not.
That's it.
That's how you add. And what I hear physicians saying is, I want to touch the patient more.
Yep.
And the nurses say that.
Yeah.
And we always want people to operate at the highest level of their certification.
Yeah.
We want physicians doing physician things, not emptying bedpans.
That's right.
You want the humanity of somebody making rounds saying, oh my goodness, your bedpan is awful. Let me get it out of here and doing it. That's okay.
Right.
But not as a routine. And you don't want highly trained nurse practitioners, advanced practice nurses, making beds. You want somebody at a lower skill level in a team. One of the best examples I've ever seen is a case where they talked about turnover time and accuracy in cleaning an OR between cases. And this study showed with a communication system among the several people who will come in and out of that room in the team. And they don't all come in at one time. Yep. They don't divide the room into fourths and I'll take this southeast, you take the north.
That's it.
And what they found was that people were cleaning some things 2 and 3 times.
That's it.
And some things none, because they didn't have a communication system. Yeah. So they automated that process where somebody had a checklist.
Yeah.
So did you do the Mayo stand? Yes, I cleaned that. And it's all documented, and error rates went down, infections went down. Yeah. And utilization of resources went up because people were doing things one time as a team. And it's a great example of how technology can improve human performance and let people do the things they want to do.
Yeah, thank you so much. So we almost getting to the end of this conversation, but I wouldn't do justice to myself if I don't ask the last question, given that we have a lot of MBA students that listen to us and they maybe want, like you guys, innovate in healthcare. So do you have any advice that you can provide to those looking to innovate in healthcare? And also regarding technology and operational aspect, do you have any advice for those looking into going in those the field of healthcare and work on that?
Well, while Josh is thinking of really on-the-ground improvements from an operating standpoint, let me give you a little framework. I only teach interdisciplinary courses. Yeah. I only teach electives. And so I build classes. I've gotten to the point in seniority at the end of my career where I pick my own students. This current practicum that I'm teaching, 40 people applied, 10 got in, 12. And I interviewed them all. And I was looking for EQ. I was looking for domain expertise. So I have an IE, a public policy, 2 biomedical engineers, this 4 management people. Yeah. And so my advice would be get in an interdisciplinary frame. Don't think I'm going to be a cardiologist, so I only want to be around them. I only want to be studying the heart. I only want to be an expert in anatomy and physiology of the heart, because nobody operates by themselves. There's never in history been a case where a doctor walked into an operating room and she said, I'm here, I'm going to cut you open. Right. And it never happens. And so it is a team sport by definition. That's and yet we don't give our students enough opportunity to work in teams of disparate people. So the model that you're in, this innovative joint MBA, MD, is an example. But within that, there's a lot of opportunities to be around other people.
Yeah, and there's themes in here that we talked about today. The silos, I think, are very, very powerful. The way that you're going to be successful in healthcare is breaking down those silos and getting everyone to work together. And I feel like anyone who's joining or thinking about going the healthcare delivery path, it's really taking the time to understand you're always in a learning mode throughout your life. I recommend that for anyone. Always be asking questions, always be trying to learn. You have to. It's that growth mindset, right? But I think that when you're entering the healthcare world, it's a very, call it, unique space that takes a while to truly understand, whether it's the acronyms, whether it's this, whether it's the interactions between the clinicians and the administrators. And in order for you to be successful, you've got to understand the processes. It goes back to, don't just try to get out there to solve it. Truly try to figure out, all right, let me ask a lot of questions and understand where these problems are and what are those root cause of problems, and then solve that. Or else you just won't be successful. Yeah. And I think we highlighted a lot of that throughout this talk today. There's so much to do and so much that can be solved by really smart people, Georgia Tech graduates, right? And I'm anxious and I'm excited to see where the industry is going to go now that a lot of people are now, like yourself, coming out and trying to understand the business and the clinical side. Yeah. We will solve healthcare in the next probably 40 years, I bet, right? It'll get solved. Our nation is phenomenal around that when you look at anything. But it's not going to happen tomorrow. It's going to take time.
It will.
The triple aim adopted or invented by Dr. Don Berwick has three goals: reduce the per capita cost, improve quality of care, and improve the patient experience. If you think about it, those three things are fighting each other all the time.
All the time. Yeah.
You could solve one of them. Yeah. If you held the other two constant, but you can't.
That's it.
So it's a constant. It's like I'm a pilot, so when I'm at the controls, I'm constantly adjusting. You do that when you're driving. Yeah. You know, if you look at a steering wheel, it's always these tiny little adjustments all the time. Sometimes you have to turn hard to avoid an obstruction. Sometimes, but mostly it's just a whole lot of slight adjustments. And in my case, it would be a little less rudder, a little more aileron, a little more down stick. And we have to think that way as leaders in healthcare.
Right. Amen. Yeah, those are really great advice. And then I think I want to thank you both, Professor Todd and Josh, for joining us today. And it was really wonderful learning from your background, your experience, and then you share with our viewers and myself like very great insight. And I want to thank you again for joining us today.
Thank you very much.
It's a great honor to be the first of these podcasts. Yes, it was a privilege. Because as the Dean and I talk about, healthcare is 20% of the economy. Yeah. And yet, until recently, I've been a one-man band at Scheller College of Business. Yeah. And I've taught 2,000 students in 13 years, but that's just a tiny bit. So we need more people interested in this profession.
Thank you so much for tuning in this inaugural episode of The Impact on the Intersection Podcast, brought to you by the Georgia Tech Scheller College of Business. We appreciate you listening and watching. You can listen to this episode on Apple Podcasts, Spotify, and SoundCloud, and watch this episode on YouTube. Thank you again.